Welcome back to Corium. I'm Brian Gilberti, and today we're joined by Dr. Tsion Firew. She trained with us here at NYU in Bellevue, and she now serves as academic chair of emergency medicine at African Health Sciences University and King Faisal Hospital in Rwanda. And she's also senior advisor to the Rwandan Ministry of Health. Her work has shaped national emergency systems in Ethiopia and Rwanda and informed WHO policy on equitable access to emergency care. Dr. Firew, it's great to have you back with us.
Thank you for having me here, Brian.
Today, we're going to be talking about Marburg virus and the recent outbreak. Now, Dr. Firew, to set the stage, could you share the experiences that most change how you practice and how you think about our role in global emergency medicine?
Thank you for that question. So probably we should talk about what Marburg Virus Disease and talk about, the work and the experience there when it happened in Rwanda. In September of 2024, Rwanda declared Marburg Virus Disease outbreak. And at the time, I did not know much about Marburg virus disease itself, but it was known that it is a family of fleoviruses like Ebola. It's a viral hemorrhagic fever. Unlike Ebola, the fatality rate that's reported is as high as 90%. And it is a brutal and deadly virus known to humanity. And all of us were completely shocked and were taken over by fear. And I'll tell you a little story about what happened. Of course, this is all in hindsight once the government and the health ministry did this meticulous work of identifying the source. And what we know now is there was a person that works in the mines, a miner, who initially had some very mild symptoms. He recovered on his own without no intervention. And then his pregnant wife fell ill, had a baby, and within a week, both baby and mother died. And his wife was in our hospital, which was one of the epicenter. Both hospitals that were the epicenter were in the city, referral teaching hospitals. And everybody that took care of her were exposed and were considered high risk. A few people developed symptoms, including a nurse. At the time, of course, we did not know it was Marburg, so this nurse was taking care in our ICU, and in our ICU, 8 doctors took care of her when she was coding. Out of the 8 healthcare workers that worked on her, 8 of them tested positive, developed symptoms within a week. Out of the 8, 4 died. The first few days, especially once it was identified as a Marburg, it was scary for all of us. We were not sure what this meant, and especially when the prior outbreaks have been fatal up to 90%. But the opportunity for us that would happen in the city, in the referral hospitals, where advanced medical interventions such as dialysis, mechanical ventilations were available. And once the disease was identified as Marburg, many of the novel therapies and vaccines were made available through diplomacy with the U.S. government and other agencies like WHO. Once those medications and therapeutics started arriving, within 10 days, we had access to all of those medications like remdesivir, which is an experimental drug that was used for Ebola that has shown to work in non-human primates and also in vitro. And we also had access to monoclonal antibodies and an experimental vaccine through the Sept Institute. So once all these things, and then we had testing for all the healthcare workers and the high-risk contacts, it was just a confluence of all this therapeutics and work with different agencies that really helped curb the fatality rate down to 23%. In the first 1 week, many of the deaths happened among the healthcare workers. After the first 10 days, then you start seeing recoveries, people being discharged. So just kind of changed the narrative, and all of a sudden, all the despair and hopelessness kind of turned around. And that's what Rwanda was able to do through this coordinated effort, bring down the fatality rate down to 23%. There's a lot of lessons to be learned, and there's been so many publications and stories that have been told on the outbreak and how it was contained. But the years of investment in building a resilient healthcare system build a huge part in containing the virus and also preventing the spread to other parts of the world.
So really a remarkable arc. And what stands out is how quickly the narrative shifted once the diagnosis was recognized and the resources were aligned. Now, Dr. Firew, I want to zoom out for a second. And from your work in resource-limited settings, what are the most persistent barriers to outbreak preparedness, and what concrete strategies have actually moved the needle when money, time, and personnel are tight?
So both in low resources and higher resource settings, there are some gaps that could be worked on. So I'll focus on some of the most common challenges, and I'll attribute both for the high income and low income. So in many, especially low income countries, there are fragmented system which leads to delayed detection. The emergency and the surveillance functions often they operate in silos, leading to missed or late outbreak identification, and really empowering emergency departments, the community, as the sentinel site can bridge this gap. And also, we've learned, I usually give this example, also what happened here during COVID in New York City during the COVID-19 outbreak back in 2020. I had traveled around late January, early February to Europe, to Ethiopia, and also to US. And the only place that had sort of a surveillance and travel screening, it only happened in Ethiopia, and most of the African countries were implementing it. I just walked into JFK. Nobody asked me if I had traveled to China or if I was in contact with COVID-19 patients. Most of the time, this is also a huge gap in high income countries, and to also have a delayed detection because of that. And in many low income countries, the other challenge is limited frontline capacity and the protection. The clinicians, unfortunately, are usually undertrained, sometimes underprotected, and they're also not part of the decision making when it comes to the surveillance. So, really embedding the outbreak recognition, reporting into the hospital, the emergency medicine, and the training is going to strengthen with the readiness. Other things that we have witnessed in low-income countries are from Rwanda, we can learn some of the positive things that happen from the strong governance and accountability system. But we've seen not only in low-income countries, but also in high-income countries where there's a weak governance and accountability. And we live in a time where information can travel to the internet within seconds. So there's a lot of misinformation that comes with that when there's not a strong message that comes from the leadership. So this unclear command structures that are created and the lack of feedback can really discourage the early reporting. And that's why the huge investment and accountability framework needs to be placed onto the governance system. The other thing, especially in low-income countries, is dependence on external programs. Some of the modalities for treatments that we use, like I mentioned, had come from outside of the country. But Rwanda is also already investing in developing their own mRNA vaccines, and this was already happening before the Marburg outbreak. So really, many of the lower-income countries suffer with relying on external programs, whether it's for vaccines or modalities. We had to get the monoclonal antibodies for Marburg from the US. So we need to really invest in local production, and sustainable progress comes really from locally owned and ministry-led partnership with universities and regional networks. Some things that also I'll add is really the resource smart innovation that some low-income countries lack, and things like digital triage tools and integration into the surveillance system that could lead to some fragments and gaps in identifying and detecting the disease very early on.
Okay, now, Dr. Firew, let's pivot to system design. If the goal is emergency care that is both responsive and equitable, what are the essential elements leaders need to build in from day one so those systems hold up under stress, which invariably they're going to have to confront?
I would say there are about 4 pillars of that. And one is investing in the workforce, right? And it takes a long time. You need a skilled and protected, motivated workforce because they're the backbone of emergency care. And this involves investing in pre-service and then service training, also the mentorship, and ensuring there's a fair compensation for the workforce that's working within the emergency care system. And that will ensure that there's a high quality and timely care regardless of the location or the resource level. The second thing I really would want to focus on is really integrating emergency care into the health system. It should not be working in silos, and they should be embedded within the national health strategies, not only the emergency department, but also the pre-hospital service. And this is going to be very important, especially as more outbreaks, epidemics and pandemic are going to be more frequent. We need to ensure that the emergency department is linked to surveillance, referral, and financing system. The next thing I would say also is ensuring equity through the design and policy, making sure that emergency care system and emergency care departments are working close with the policymakers and addressing the needs and the protection of the vulnerable groups. The last thing I would say is the importance of data. You need real-time data with dashboards that provide a feedback loop between the clinicians and the policymakers, and that could really help you develop a tailored intervention and innovative intervention to expedite the responsiveness. And that is an important thing also to think about, even with the limited resources.
Okay, now many listeners, and I'm sure people that see your work and the work of your colleagues, are going to be inspired and want to contribute responsibly. So, for clinicians who hope to get involved in global efforts, how can they do that in ways that create durable value for local partners? And on the flip side of that, if you could just comment on some of the pitfalls that you've seen.
Okay, so again, I'll just limit it to four. One, I would say for many clinicians and also people that are in training, start small and build trust over the years. Meaningful global works begins with humility and relationship, not scale or visibility. And really, people need to understand and looking into understanding the local priorities and also making sure there's a sustainable change that could happen through partnership, not just a presence. And important to show up either in person or also if we're doing it to continue virtually, but making sure that it's a sustainable and long-standing project. And I would say this also to my many of my trainees. It's important to be the expert in the field, but you need some knowledge in other places. So be T-shaped and deep in one area, whether it's emergency medicine or other medical specialty, but you need to have the fluency across other things because at the end of the day, policy is driven by the policymakers, and finance and the data drive the decision making that happens. And you need to be fluent in all these other things. The third thing I would say is really focusing on the knowledge transfer and capacity building. And goes back to my earlier point, which really helps build sustainable intervention. True impacts means making yourself less essential over time. You have to prioritize mentorship to different models and sharing different opportunities, whether it's authorship or leadership, shifting from the helping attitude to co-creation. And some of the pitfalls, I mentioned them, but really to shy away from the savior mindset and short-term missions that do not build or contribute meaningfully, but to really look into long-term commitments that comes over time with partnership. And that requires humility, dedication, and of course, fulfillment, but the priority should be really the community that you're serving.
Okay, very well said. Now, finally, I want to end with this, and I know it's going to be a difficult question to answer, but I'm going to pose it anyways. Looking ahead, what emergency global threats do you think are going to shape the next decade in emergency medicine, and how should we be preparing for that if we can at all?
So I think the next decade will challenge emergency medicine in unprecedented ways, shaped by the convergence of climate change, different outbreaks, conflicts, displacement, and technology, AI disruption. So I think we should really look into how emergency medicine system could help alleviate some of the challenges and be at the center and the leader in it. And starting with climate and environmental crisis, we see extreme heat, floods, things like vector-borne illnesses are all going to walk through our emergency department. They will strain our emergency systems. So we should really be involved in all investing in climate resilient infrastructure, not only for our emergency department, just for the community. Other things that are going to be really challenging, of course, in addition to outbreak, is antimicrobial resistance. As we know, future outbreaks will emerge faster than our current system. And really the question of biosecurity comes along with that. But that's going to be one of the biggest challenges, just not only for emergency, just for the healthcare in general. Things like conflict, displacement, and urbanization, these are not simple things to just mention and go by, but we've seen mass migration, humanitarian crisis, overcrowded cities. They will drive new models of emergency care that are mobile, scalable, and inclusive, and training our clinicians and our students in resilient healthcare system that are also ready for addressing crisis, mental health, and cross-border coordination. The last thing, of course, is really how we're going to use digital tools and AI into alleviating some of the challenges that we face every day in our emergency department, but that will also continue to serve the community. And we need to invest. There's an access to data governance and ethical AI, and really look into the local capacity to adapt these digital solutions. So I think that's really all in summary, but at the end of the day, it's really going to come to how well we respond to this at a national level, but what each of us as emergency physicians are doing to address those things in our everyday life.
Dr. Firew, thank you for sharing your experience and your perspective. We really appreciate your time and all the work that you're doing.
Thank you.